Now coming to simple diffuse hyperplastic euthyroid goiter, as you can see with the picture, that this is generally enlargement of the thyroid gland. It's a euthyroid enlargement of the gland, result from stimulation of gland by TSH in response to chronically low level of circulating thyroid hormone. As I have already told you that this is a feedback mechanism, the positive and the negative feedback. If the thyroid hormones are low in the body, so they are going to give a negative feedback to secrete TSH, and this is how it is working. So this is a negative and positive feedback mechanism. So it's going to there will be more TSH for thyroid gland, and it's going to produce it's going to get enlarged in the size. Persistent growth stimulation, diffuse hyperplasia, all lymphocytes are composed of active follicles. Iodine uptake is uniform, so it's a uniform enlargement, so iodine uptake is uniform. And diffuse hyperplasia is reversible. If TSH stimulation ceases, we can give externally thyroxine to decrease the size of the thyroid gland and to suppress the TSH secretion. So the hyperplasia can be managed, and these are few physiological conditions. One is at the age of puberty, when the female is entering into childhood to puberty, so it's a increased demand of the thyroid gland, which results in increased search for TSH, resulting in diffuse hyperplastic goiter. And it also occurs in pregnancy, the physiological goiter, which we say, in which there is a high metabolic demand of the thyroid gland. And once that scenario is over, that once the puberty age is gone and once the pregnancy is being done, so it comes back to the normal thing. Iodine deficiency goiter initially starts with diffuse hyperplasia, and then it turns into nodular goiter. So this is one of the also thing that initially the iodine deficiency also presents with this thing, the diffuse nodular goiter. The next one is the simple euthyroid multinodular goiter. As you can see in the picture, this is the multinodular goiter, which is euthyroid. It means that though this gland is so much enlarged, but still the thyroid hormones are within the normal limits. So it results in the fluctuating stimulation and mixed spectrum developed in the gland with areas of active lobule and active, both the inactive and active lobules. All lobules are initially active and vascular, and if the hemorrhage occurs, it can cause necrosis in it, and necrotic lobule then form nodules, and the nodules are either filled with colloids or the active nodules are very few, and it results in a nodular goiter. So this is the pathophysiology, that there is sometimes hemorrhage in the nodule, which results in necrosis, and then form nodule, and this result in nodular goiter. And most nodules are inactive, that they are not producing any active hormones. Active follicles are present in the internodular tissue, so in between the nodules, like you can see here, they are the active glands, and these nodules are basically inactive form of the thyroid tissue, which are not producing any thyroid hormone. So as I have already mentioned, that it doesn't depend on the size about the toxicity of the thyroid gland. Even if even a large thyroid gland cannot be toxic, and even a normal thyroid gland can be very toxic with this very small nodule in it. So it's about the activity of the gland. And the other thing is that you can see here that what are the causes of, if someone asks you that what are the causes of nodular formation, this way you can say that it's the hemorrhage, which can cause central necrosis, and then necrosis can lobules can form to nodules, and nodules are generally inactive, so these are the inactive part, and the in between nodular segments are basically hyperactive and producing thyroid gland thyroid hormones. This is the cross section of the thyroid gland. You can see the bleeding and the dead necrotic segments, and showing the secondary hemorrhage and necrosis and the cystic changes. You can just well imagine here that the in-between tissue is normal, but the nodular ones are necrotic tissues. And nodules may be either it will be colloid or cellular. On macroscope, nodule predominantly give an impression of a solitary thyroid nodule, and ultrasound is useful to detect other small nodules which are not palpable clinically. Common complication. What can a complication occur in a thyroid nodule? This is one of the frequently asked questions in exam. It can result in cystic degeneration. It can result in hemorrhage and calcification. Hemorrhage can occur and become more painful and rapidly increase in size. We do come across the patients which say that I have this nodule for last many years, but for the last few days it has suddenly increased in size. So it means that there is a certain hemorrhage in that nodule and it has become painful. And the differential diagnosis is autoimmune thyroiditis and carcinoma. It can go for calcification if there is, you can feel the hard sensation, so it means that either it has gone towards the calcification phase or it has turned into malignancy. So sometimes the calcification is very, you can mix the calcification with the malignancy. Now, complication of solitary nodule of thyroid, complication of ulcerative colitis. It can cause tracheal obstruction by displacement of the trachea. It can cause thyrotoxicosis and even the carcinoma can occur in the simple nodular multinodular goiter. And there is a likely chances of turning it into a cancerous form. The hyperthyroid goiter you can see in the Graves' disease is diffuse intake and the increased uptake of radioactive iodine, and the second one is it could be diffusely producing hypertrophic hyperthyroid gland, or it could be a nodular segment in the rest of normal thyroid gland. So if it's a diffusely producing hyperthyroid gland, so it is called Graves' disease, in which it's an autoimmune disease which we are going to discuss, and the other one is that it's a normal thyroid gland which a segment producing more thyroid hormones, which is a toxin nodular goiter. This is just a picture again to show you the exophthalmos we have already discussed in Graves' disease. You can see that this is a toxicity in the Graves' disease and with lead lag and lead signs retraction. And this is toxin nodular goiter. You can see a large toxin nodular goiter when large nodule predominates. So this is a multinodular goiter with one large nodule that you can see in the picture. Thyroid scan shows that this is the hot nodule in the apex of the left lobe and middle at the right cold nodules in the right lobe. So, but one hot lobule is also present, and the treatment is surgery. This is the cross section of the thyroid gland which we have taken out. This is one of the other pictures, the larger keloid in the left pole. You can see there's a large keloid here and a smaller keloid in the right pole. And rest is the multinodular goiter. So this is keloid producing a large keloid low segment in the right lobe of the thyroid. This is the right lobe and this is the isthmus and the left lobe, and you can well imagine the size of the nodule in the both the lobes. Now, what is solitary thyroid nodule? This is a very important question which is being frequently asked in vivas and even in the written exam. So you can see that solitary nodule is one single nodule in a normal thyroid gland. So in 15% cases, this is malignant, and the malignancy is papillary, most common follicular, medullary, and anaplastic. There are four types of malignancies in thyroid gland. One is papillary, other one is follicular, medullary, and anaplastic, and the other one is benign. Another case is benign. It could be hyperplastic or cold nodule or follicular adenoma or a cyst. So if you get a solitary nodule and someone asks you a question, so you can just broadly classify that it could be as a single nodule in the rest of the normal thyroid gland, and it could be both malignant in 15% cases and 85% cases benign. And in malignancy, we have got four types of malignancy. One is papillary, other one is follicular, medullary, and anaplastic. And in benign, it could be hyperplastic or cold nodule, follicular adenoma, or a cyst. Now this is a scenario. The 16-year-old female presented asymptomatic palpable thyroid nodule notice on the routine physical examination specimen of the thyroid. Now same patient turns out to be papillary carcinoma. So it was a normal 16-year-old female with just one nodule, and eventually went on the dissection and turned out to be a papillary carcinoma. So you have to be very conscious about treating a patient with a solitary nodule thyroid, because there are likely chances that it could be malignancy. You are not just going to give a clear hand that because of the age, because in a 16-year-old female, if this is presented with a solitary nodule, turned out to be papillary carcinoma, so there is no age limit for this disease. gross specimen of thyroid containing partial cystic mass and the papillary projection. You can see the papillary projections in this nodule, and this is a case of differential diagnosis of a cold nodule. As you can see in the thyroid gland, there was a cold nodule, and when eventually we dissected out and we done the FNS, it turned out papillary carcinoma, and this is the cross section. You can see the papillary projections in the thyroid gland. Solitary thyroid node, these are other nodule on the left side of thyroid, and the nodule proved to be malignant. You can differentiate between the nodules I have shown you before in the diagram, that they are more of a colloid nature, and this is somewhat more ardent sort of nodule and differ from what I have shown you before. So this is the ultrasound showing a solitary nodule here. You can see this is thyroid gland and a single nodule over it, and this is the thyroid scan of a patient with solitary nodule. And now coming to the retrosternal goiter, this is another type of goiter in which we have to it extends, as the name says, it's a retrosternal goiter. Retrosternal goiter means that it is extending beyond the sternum and causing the compression symptoms of the structure passing through the sternum. The most important thing is that this is displacing the trachea, the left lobe, and it extends between. You can see that trachea is being displaced. This is one of a difficult patient to treat because it extends beyond the sternum and cause compression on the thoracic outlet, and resulting in a thoracic outlet syndrome, in which there are compression symptoms on trachea. Patient presents with dyspnea on esophagus. Patient complains of dysphagia on the nerves, and with engorgement of the veins, and this is, you can see the engorgement of the vein. It is extending the retrosternal puffiness of the face. This is, and we have to manifest this clinically through Pemberton sign, in which we ask the patient to raise the hand, and if the face gets engorged and venous congestion, means that the thyroid extending retrosternally. Generally, they are large glands, large thyroid gland, which displace the trachea to one side, cause compression symptoms, sometimes voice change. So a large thyroid gland which extends beyond the sternum can result in, is called the retrosternal extension of the thyroid gland. Sometimes we have to go for sternotomy in order to get a proper exposure of the gland. And the Pemberton sign is the one in which is the clinical manifestation of the retrosternal extension. The other one is the Cocker sign. In Cocker sign, we push the large thyroid glands to one side and causing the, and make ask the patient to take a voice, and if there is a stridor on the taking a deep breath, so it means that it is causing compression of the trachea. So I'm going to manifest these signs on the clinical patients, and I'm going to show you in the clinical methods. So in cases of retrosternal extension, this is basically a large goiter which extends beyond the sternum, causes thoracic outlet obstruction, causing signs and symptoms of compression of the vital structure passing from sternum to the neck, in which the important ones are trachea, esophagus, veins, and nerves, and the larynx, and it can cause even hoarseness of voice, dysphonia, dysphagia, dyspnea, and difficulty in breathing. And you can see in the picture there engorgement of the veins because of the compression of the large veins with the retrosternal extension of the goiter. So we are coming to the end of the thyroid gland and the topics which need to be discussed, and we are going to discuss about the relevant questions in our next lecture. And if you guys have any queries or questions, please inbox me or WhatsApp me about the questions. We are going to address accordingly. Jazakallah, and thank you.